Hi, I'm Danielle Abbitt. I'm a resident at University of Colorado, and I'm presenting on telehealth outcomes and follow-up after cholecystectomy in our veteran population. This is in association with Rocky Mountain Regional Medical Center. I have no disclosures to report. We know the COVID pandemic has brought about many challenges to healthcare systems. One thing that has come out of it is the substantial rise in utilization of telehealth. However, we note they've been utilized primarily by non-surgical subspecialties, with surgery and surgery subspecialties lagging behind. This could be due to a reluctance of surgeons to transition their practice, unfamiliarity with telehealth platforms, or the need to perform a physical exam in order to determine the appropriate surgical approach. We also know from the COVID pandemic, certain patient populations are at a disproportionate risk, particularly those 65 years and older, and those with underlying medical conditions. Our veteran population is unique. Of the 9 million veterans in the US, over 50% are greater than 65 years old, compared to just 18% of our civilian population. They're also 14 times more likely to have 5 or more underlying medical conditions, and 14 times more likely to have a poor reported health status. The veterans that we in particular work with are in the VISIAN 19 group, Veteran Integrated Service Network 19, which is one of the largest in the States. We take care of patients across 10 states in the US. So given what we know about the veteran population, our specific veteran population, and the opportunity to better utilize telehealth, we sought to evaluate patient demographics, characteristics, and their outcomes after following up via telehealth after a low-risk procedure, in this case, a cholecystectomy. This was a retrospective review over 2 years at a tertiary VA medical center. We included all patients who underwent cholecystectomy by CPT code during those 2 years. We had several exclusion criteria: patients that had non-absorbable suture placement, had a reoperation during their index admission, were discharged with a drain in place, a new malignancy diagnosis, or if they were lost to follow-up and did not follow up within 3 months. Our primary outcome measures that we sought to evaluate were any complications, 30-day readmissions, ED visits not requiring readmission, and need for additional procedures. We also evaluated patient demographics and perioperative characteristics to better characterize our patient populations. We had 179 patients that underwent cholecystectomy during the study period, with 30 excluded due to the previous exclusion criteria. Of that, 149 patients were eligible for telehealth. 20 patients were also excluded because they were due to loss of follow-up. After that, we had 52 patients that followed up with telehealth and 77 that followed up in person. If we look at the table on the left, we see our demographics and our perioperative characteristics. It was important to note that our higher risk patients, so our higher BMI, advanced age, higher ASA class, did not preferentially follow up in person versus via telehealth. Also, we looked at distance from the VA medical center, which is traditionally thought of patients at a distance will follow up via telehealth and patients that live nearby will follow up in person, and we did not find that to be true. Looking at our primary outcome measures, there was no difference in readmission, ED visit without readmission, complications, or need for additional procedures. Several complications did occur to our patient population. We had cardiopulmonary complications, pneumonia, PE, 5 infectious complications, and 1 postoperative bleed that did not require readmission or reoperation. For additional procedures, 2 patients required ERCP for retained stones. We did have 2 reoperations. Both of those patients had followed up in the in-person group, and 2 patients required bedside IND or reopening of their incisions. So we found that telehealth is not inferior to in-person follow-up in our specific veteran population, as demonstrated by the no difference in their complication rate, admission, ED readmissions, 30-day readmission, visits, or need for additional procedures. So while we may have a reluctance to transition our practice, it should be considered an option for all patients undergoing a low-risk procedure like a cholecystectomy. Thank you, and any questions?